Good evening, everyone. This is the second webinar of our master course in breast cancer, which we are organizing with FSIBC in collaboration with APSI. So today we will be focusing on radiology in breast cancer. And we have 4 sessions today, followed by QA and expert comments. So to start with today's session, I would like to invite Dr. Vaishali Zamre. Ma'am is Director and Head Breast Cancer Surgery at Andromeda Cancer Hospital, Kundli, Sonipat, for the welcome address. Over to you, ma'am.
Thanks, Dr. Prikshi. So once again, a very warm welcome, dear faculty members, as well as the delegates on this platform. As we all know, you all know that for last 3.5 years, we have been consistently organizing webinars on various niche topics in related to breast cancer. And since last 1 month, we have started a new master course, which is going to cover in nearly, I think, 24 odd sessions. We're planning to cover all the aspects related to breast cancer, including radiology, pathology, molecular oncology, everything. So that is what is our intention to do. And we know that today's session is dedicated to breast imaging, which is going to cover the fundamentals as well as the recent advances in mammography, ultrasound, MRI, and Dr. Madhavi is going to take us through the interpretation of BIRADS. So with such a great faculty on board today, I'm sure this is going to be a great learning experience. So without wasting any further time, I'm going to hand over to Dr. Prikshi for the further proceedings. Dr. Prikshi, over to you.
Yes, ma'am. So before we start, I have certain requests to the speakers. Please stick to your scheduled time. To the delegates, please put your questions in the QA box. And there is a different link for joining the delegates, which is put in the chat box. So you can please move towards that. This is the faculty link. To the speakers also, please stay after your talk so that we can have some engagements in the QA session. So we'll start with the first session. Ultrasound indeed is a valuable tool in breast imaging. And to discuss its importance, we have with us Dr. Palak Popat, who is Professor of Radiology at TMH Mumbai. Over to you, Dr. Palak.
Yes, thank you so much. I would like to share my screen.
Yeah, it's visible. Yeah.
All right. Okay. So thank you so much.
Please put it on. It is. Yeah. Now it's fine.
Yeah. Thank you. So my pleasure and honor to be on this platform and to just unleash on what ultrasound can do in breast imaging. So when we talk of ultrasound, we essentially talk of a B mode, a color Doppler, and elastography. So may I just verify that most of the delegates attending the session are going to be non-radiologists?
Many of them will be surgeons, general surgeons. Some of them will be breast radiologists also.
Okay, sure. So, so B mode is similar to a grayscale ultrasound that we see. So everything is in shades of gray, and we see a mass. We see the normal breast ultrasound in the background. So that is a B mode. Color Doppler is when we throw in some color. It is essentially based on the principle of vascularity. If there is vascularity, there will be flow. So there is a common myth that, oh, there was vascularity, so this is malignancy. Well, no. Most often, more vascularity is seen in inflammatory conditions. So perhaps it can just tell us whether there is whether it is solid or cystic, because sometimes we cannot make that out either. But if the solid lesion is really just a fibroadenoma or a malignancy or an inflammation, we may not exactly know. The second caveat is vascularity may not always be within the lesion. If there is a solid duct, there can be vascularity around it as well. So that can be also an indicator that we need to see something carefully. The next is elastography. So elastography essentially measures a tissue stiffness. So we have different shades ranging right from blue to red. And depending on the color coding, a lesion may be either soft or hard on elastography. Again, it has its own caveats, like by dictum, everything that is hard is bound to be cancerous. So a hard lesion on elasto will be a malignancy. However, sometimes cysts cannot exactly give you the right elastography. They can give you a mixture of things. Perilesional stiffness is often an indicator of soft tumors such as mucinous carcinomas or triple negative tumors. So they don't necessarily have to be hard inside. They may be very soft, they may be necrotic, and we can have a perilesional stiffness. Similarly, something which is stiff on the peripheral side can also be seen in intense inflammation and a stiff breast that can happen in granulomatous mastitis. So there is no mathematics over here that one equates to another, but that is exactly what is required. We need to put in all our modalities in one basket and have a clinical perspective to give a possible diagnosis. Now, whether an ultrasound is going to be complementary versus supplementary. So let us look at this mammogram. So this is a dense mammogram, and I'm seeing something here. This may be a mass, I'm not sure, in the upper outer quadrant. I have to do an ultrasound. There is no choice, all right? So it is a complementary modality, supplementary because it will be done after the mammogram is done. And what do I see? I see a very normal breast. So is this a match or not? It is very much a match. So the echogenic areas are fibroglandular parenchyma. I have fat component over here. And when we see these linear bands out here, there is a linear band going here. There is a linear band. So this is how her breast parenchyma is. So this could have been a category 4 on a mammogram and an ultrasound. I'm 100% sure this is an island of stripes of compact fibroglandular parenchyma intervening with fat. So I'm not worried about this lady, and she could very well go as a benign condition. Something that is seen over here, this I would say maybe benign or not. So this is a category 4. Somebody called the microcal here, but I would see that it is away from the lesion and it looks very well and benign like a fibroadenoma. So this would be a concordant finding that I'm not really worried about it. However, sometimes they don't seem too well on the mammogram, and on the ultrasound, we have this lobulated appearance. There is an echogenic halo, some amount of shadowing in some part of it. This would be a category 4C, irrespective of how it looks like. So this is again concordant with the mammogram. So I would say an ultrasound goes very much hand in hand with a mammogram. Here I have an asymmetry with calcifications which look benign. And let me look on the ultrasound, whether it is coarse heterogeneous or benign. We have a duct out here with the calcification seen within the duct. No significant vascularity. Calcification is seen very well on the harmonics. This is all inflammatory, and this was benign. So it is concordant with the changes that were seen on mammo and the ultrasound. Again, a very complex looking calcification. The ultrasound gives us a very clear, benign appearing finding, and we are not worried about it. So we would call it a category 4. For A, perhaps, it was benign, and it is concordant, so it would not go in for a rebiopsy. So what is ABUS? ABUS is an automated breast ultrasound where the ultrasound can automatically be performed without scanning, but the scanning happens automatically on the breast and the images are seen as a 3D format. So we see images like a CT scan in the coronal plane as well as in the axial planes. So that helps in a better perspective and a better location of lesions with respect to each other and lesions in the supine position of the breast. So coming to the value in day-to-day practice of reloc ultrasounds, I have not included BIRADs and teaching slides of ultrasounds because that is more for the radiologists. What I wanted to bring in out here is how it matters when would you ask for an ultrasound, or what do you mean by a radiologist asking, okay, I think I want to have a second look on an ultrasound. So just have a look at this and pause for a moment. This is my concept of a blooming flower or the blooming breast, and I shall explain you how and why. So let me show you a clinical context where there is a 38-year-old young lady. She has no comorbidities, history of breast cancer in the mom and sister at ages 49 and 42 respectively. She has a lump in the left breast since 4 months. This is a mammogram, and then it is a very dense and a busy mammogram, and we all hate to report such mammograms. Nonetheless, we have to do our job. So now my job is to hunt for something I'm worried. The only thing I found here is a little bit of architectural distortion. I feel something is pulling in out there. It is not symmetric and it doesn't look very good. On the MLO view, maybe here, but I would honestly not be too sure. So the ultrasound definitely shows us the lesion without any doubts, and there is no rocket science in detecting this lesion. So fair enough, we have detected this would be a category 4C. It has speculated margins, somebody can call it 5. It has an intense ecogenic halo around it and a posterior shadowing. So this is a BI-RADS 4C lesion or a BI-RADS 5 lesion. It is very highly suspicious of a cancer. Some peripheral vascularity, hard on elastography. So yes, so always a hard and a soft depends on the institute and the machine. So look at the bar out here. So the higher pressures, 144, corresponding to the harder areas, and the softer areas are seen in the vicinity. A ratio is calculated on elastography, which is a normal ratio compared to the ratio of the stiffness. Now, on the ultrasound, so as we expected that the tumor is not seen well, so I have no idea what else is lying in the breast and how it looks like. So essentially, it was like a blank check that I would say the mammogram was. So we start hunting for every small thing that we see on the ultrasound. And so we found something out here and we found another lesion out here. So there are some lesions. Well, I'm honestly not very worried about these. These are very soft on elastography. There are ecogenic septae, well-defined, horizontal, wider than tall, posterior acoustic enhancement. Everything fits into a classic fairy tale appearance of a fibroadenoma. So maybe yes, but the point is she has a very dense mammogram. We don't know what else we are missing. So she undergoes an MRI to look for extent of disease and if there is anything additionally. So now this is her MRI picture. And what we do see is that, let me show you, this is abnormal. There is this posterior speculation on the T1, on the T2. This is the post-contrast. This is a diffusion. And okay, so that is a lesion in all the sequences. And this is a diffusion restriction, which is dark on ADC. So are we concordant with the location? Yes, it is posterior just above the pectoralis on the MR. The pectoralis is here and it is probably, we would have said it is involving the pectoralis. So it is a concordant location of the finding. Now my job is to see what else is seen on the MR. So we have this another lesion that we see in the left breast, and it is dark on T2 with classical non-enhancing septae on MR, which we deem as very highly suggestive of a fibroadenoma. So I would have an ultrasound correlate for this, and I see, so this is fairly in the upper center region. The ultrasound also shows there was this lesion in the left breast in the upper center region, and I am concordant with my findings with the morphology. And I'm happy that, all right, I'm good to go. Now, what else do I see? So coming to the opposite breast, I see something out here, and this is the subtracted image. So this is again T2 dark, but it does not have the best margins, I would say. It has some microlobulations, and I'm seeing perhaps 1 or 2 non-enhancing septae, and I have to hunt for it on the ultrasound. Now, where in your mind would you imagine this lesion will be? So if I am new to MR, I would imagine that this is going to be far posterior. It is really posterior all the way down. So I might just think that I might not find this lesion on ultrasound, and perhaps somewhere in the center of the breast. So I might expect a 12 o'clock position deep down in the posterior parenchyma. So now I do a relook assessment of the ultrasound, but the only thing that I'm finding is something around the 2 o'clock axis, and this is not posterior. If you see, there is no parenchyma here. Overall, there is an attenuated parenchyma, and I think I'm fairly superficial in terms of the location of the lesion. So here, this is not concordant to my early imaging understanding, but let me have a closer look and closer understanding. What I do mean to understand by the concept of the blooming breast. So this is how the position of a breast is in an MRI because it is in a compressed state. So let me say I have 2 lesions out here, and let us see what happens to the breast when the breast from the compressed state will fall on the ultrasound table. It blooms out. And as it blooms out, the breast is going to move out in both directions from what we saw. Now, if I have to look at the location of something which is so compressed, it is going to move either inside or outside. So let me flip. Now, when I flip the breast, what was seen here will move on the inner aspect, and I have an outer aspect. Now, if the lesion is quite in the center, as was my lesion, let me try to expect, I think I should expect something out here, but no, as the blooming breast concept, this is going to move out, and so is this lesion going to move out. So this is on the inner side when I flip the image. So in the inner aspect, so I expect the location to be somewhere at the 2 o'clock. So then maybe I think I'm concordant with the location of the MRI seen with the location of the ultrasound. However, I still thought this was way deep down and I do not have that thickness of the breast. Why is that so? So imagine a lady lying in the supine position, and if I have to screen her, my probe will move in this direction, and I hardly have any breast parenchyma out here at the 2 o'clock position. So this is a fairly superficial lesion. So now if I expect, so the probe is actually going to come on this part of the breast as the breast falls outward. So I expect a superficial lesion, and this is a fairly superficial lesion, very minimal breast parenchyma here, very minimal breast parenchyma here. So this is quite a concordant find, and now I am convinced that I have a good relook ultrasound for the findings that I was hunting. Once I'm satisfied with all my concordances, I think I'm good to go with going ahead with my diagnosis. Another example of finding, let's say, clumped non-mass enhancement on the MR out here, and I mean, this had to be biopsied, but when we were looking at a, okay, I have lost the image for this, but there was a faint, ill-defined hypoechoic lesions on the ultrasound, which did match, and we similarly find it by a triangulation. Role of ultrasound for additional lesions, we always want to see multicentricity, multifocality. Gone are the days when our challenge is this a cancer or not? I think in my institute, with the amount of BCTs being so high, I always say the shoulders put the gun on my shoulder. I need to see whether it is multicentric, multifocal, am I leaving out disease or not, and giving the surgical extent. And that is what I think takes most of my time and resources put together. So we definitely have a mass out here, which is a BIRATS 5. And well, there is no rocket science in diagnosing this, but there was something which was also seen far away in the opposite quadrant. And so this, we then start hunting for it in the initial ultrasound, it was missed out. So here is the obvious mass that we see, which is hard on elastography. And there are these small little speculated masses which are in the outer aspect, and this was concordant with the additional findings seen on the MRI. So this is now reported as a multicentric mass. Multifocality is when the additional findings are within 5 centimeters from the index mass. So there is something which is seen here, I would say an ill-defined asymmetric density, and an MRI was run in for her, and we did, so this is a non-subtracted. So there was some additional lesions. So of course, you know, the disease extent of surgery would change. So this is the, I mean, I would not run through the sequence for the want of time, but this is a lesion here, and there is an additional focus here. So we try to look for the additional focus, obvious malignancy here. This is the obvious malignancy with vascularity, kind of perilesional stiffness, but though soft in the center on elastography. There's a small little lesion seen next to it. The MRI images again, but there was an additional lesion also seen next to it, which had kind of angular margin. So if you see the MIP image, we have the mass here. We have an additional focus here and here. Now, the point is, if there is going to be a palpable disease, which is very well defined, and just with the minimal requirement of having a good less than 1 or 2 millimeter of normal breast tissue on the histopathous clear margins, there is no interconnecting abnormal breast parenchyma, and there is an err towards missing out additional satellite lesions. So multifocal lesions also becomes important and imperative to look for having good resection of margins. So again, these are some multiple areas. So if I had to give the disease, I am finding additional areas on the ultrasound which I can map on the skin, but my extent of disease would include all these enhancing additional areas, 2 or 3 of which are also seen on the ultrasound. Coming to pregnancy and lactation, where ultrasound is the modality as the first imaging tool of choice. So here, a very dense and busy breast parenchyma again that we see. And very logically, she had some symptoms, and she was clearly not lactating well enough from one side compared to the other. And so this is how her MRI is on the T2 weighted images. And we see a whole lot of lactating changes in both the breasts, but we have additional obstructive changes where there are dilated cysts, ectasias, and some benign tumors. This is the post-contrast image in which we see non-enhancing cysts. So we are not worried. They're there on both sides. This would be like a hormonal change. Again, multiple cysts. But now we are seeing something that starts coming up, some small little enhancing foci here. And then we have another mass out here. So now once the MRI is done, our job is to look at what was enhancing. We forget the others. And now I need to correlate, go back to the ultrasound to try to find the answers. So we do find something out here which is solid appearing. This looks relatively benign, probably also had some septum out there. So now we start looking at detail, try to start correlating. And at one point of time, we see this little lesion with internal enhancement. And this is the lesion. There were cysts on both sides, which are non-enhancing. So we have our own anatomical markers in terms of positive findings or cysts or malignancies, and flank and try to identify which is the lesion that we are worried about amongst the plethora of lesions to ideally decide, because there would be some 10 solid lesions here, but I just am worried about 2 solid lesions which are enhancing. So triaging becomes important and relook ultrasound becomes important to precisely go where we want it to. Here we have a lesion where there are lobulated enhancing masses, the second one, and I can find the dilated duct or a complex cystic lesion with internal lobulated solid component. So yes, this matches, and these did go in for a biopsy correlation. There is a separate session which is going to be covering interventions as well. But just to cover up what can be offered in ultrasound-guided interventions: core biopsies, vacuum-assisted breast biopsies, extended VABs, vacuum-assisted excisions, hook-wire localization, clip placement, and guiding for cryoablative therapies. So a diagnostic example would be like, I'm seeing something on my many microcals on the mammogram, and we do want to biopsy, but definitely we are seeing something on ultrasound. So instead of doing a stereotactic VAB, we can target more areas and the lesion as well as the microcalcifications. So when there is a combination of microcalcifications and a lesion, we may choose to sometimes target under ultrasound. An extended VAB, for example, I have this case here where there is a solid lesion, some vascularity, and a duct, and there was one lesion benign, but there were many lesions. So then, instead of having an extended surgery, and the breast was almost nearly full of such lesions. So there is a limit to how much one can resect, and for a benign lesion, it is not justified to resect multiple lesions. So in such a scenario, sometimes you can do an extended VAB where almost about 4 to 5 lesions, which are just within one quadrant or 1 or 2 o'clock positions. So this is 7 to 8 o'clock positions. We have the markers here. So most of the lesions were targeted with the same needle under the same single approach and just changing different directions. One is to get more sampling of tissue to rule out any presence of atypia, and we are not contaminating because we are confining ourselves to 1 or 2 o'clock positions. So this can help in a diagnostic dilemma where there are multiple lesions seen. So again, this was the same patient, so that would be an extended VAB. Again, some case, where there is some enhancement seen out here on the MRI and 2 or 3 lesions. And so it was the same case, and these are all complex papillomas with UDH. So I think excision is something which we tell people we always counsel women not to get benign fibroadenomas excised. But beyond that, certain indications when something is atypical, though a core biopsy is benign, you don't want to take a chance and you still want to have a resection, or if the lady wants a removal because she wants it for whatever cosmetic reasons, then no-stitch vacuum-assisted excision is quite a choice that can be offered. This is an example of a lesion, very superficial, but we can give good amount of we generally give lignocaine or normal saline. We cause hydrodissection superiorly and inferiorly. So we see this, and the entire plane is created to dip down the lesion, and then an excision is performed. A clip placement is mandatory, and this is the hematoma assessment. Always keep that in mind. And we see the clip out here in C2, and this was a benign lesion. So I would just end myself with learning points. So, this is just my concept of explaining the blue vein flower concept. Prone to supine flip is important to understand. There is a natural fall outwards between a mammogram and an MRI and an ultrasound. And ultrasound is the friendliest position for the surgeon because that is the only position which replicates the surgical position. So the radiologist needs to be very well versed with the tips and falls of the lesion and changes with respect to position for the surgical outlining. And proposition and angle can literally change position of a lesion. I might find, so as a radiologist, I would usually have a patient in decubitus position and then I scan the lesion. So I would say something is at 4 o'clock and 2 centimeters away. But if I care to put her back in the supine position and re-see, the lesion could have moved almost to 5 o'clock or 6 o'clock, and it might just be about 5-6 centimeters away. So prior to surgery for any localization, it's probably a good idea to have a reassessment of the location of the lesion for cross-checking. And I would say be broad-minded to encompass and include all imaging modalities to give one common answer. Thank you so much.
Thank you, Dr. Palak, for the great presentation. And really, the pictures are much clearer by now. So now we'll move towards the next session, in which we'll discuss regarding mammography. So mammography has actually come a long way and it has evolved significantly. To discuss its journey and the continued advancements, we have with us Dr. Smriti Hari. Ma'am is professor in Department of Radiology at AIIMS, New Delhi. Over to you, ma'am.
Thank you so much. So, yes, so now from ultrasound, let's move over to mammography, the mainstay of imaging in breast diseases. So as the title slide says, how the mammography has progressed from then to now and what is next for us. I'll try and cover this. Next slide, yeah. Will I have to say next slide? I think I should have shared it myself then.
Ma'am, you need to tell me next slide.
Oh, okay. So mammography is nothing but an X-ray of the breast, which has to be modified because now you want to evaluate low density soft tissues and you need high contrast and spatial resolution. So basically, this is the mammography equipment in which there is an X-ray tube, a compression plate, and an image receptor. And then I think I would like to share it from my screen because otherwise the pointer will not work as well, right?
Sure, ma'am. I'll stop share.
Yeah, please stop share. I'll share. Yeah, is it visible?
Yes, ma'am.
Yes, ma'am.
Okay, so that will be much more in my control. So every mammography consists of two basic views, and we are often asked about the radiation dose involved. So you can easily say that each view is like one chest X-ray. So if you're doing four views, two MLOs and two CCs, it is like 4 chest X-rays. So this is the mediolateral oblique view, in which the maximum breast tissue is covered. And this is the craniocaudal view, which gives us the orthogonal perspective. Why oblique and now why not a dead lateral? Because to get more breast tissue, we have to harness the obliquity of the pectoral muscle. But we know that mammography has its limitations. It's an imperfect tool. 15% false negative rate is there. And especially the sensitivity drops in women with dense breasts. So as you can see here, in a fatty breast, you are able to see a very small cancer. Whereas in a dense breast, a large cancer like this is hiding somewhere here and only causing some subtle architectural distortion. So why is it so? What is the reason for these limitations? Mostly it is the density of the breast, in which the dense tissue is white and the cancers we are looking for are also white. So they overlap with each other and we can't see them. Then there are a lot of overlapping structures in the breast which may hide a pathology as shown here. And sometimes even if the breast is not very dense, it has a very complex appearance. So that also makes picking up subtle findings very difficult. So that's how the concept of breast tomosynthesis came because this can improve visibility by taking multiple slices instead of a single 2D image, and in which you'll see slice by slice, you'll be going through the breast, and hopefully away from the superimposing structures, you should be able to see the abnormality in some of the slices very clearly. So that is the premise of tomosynthesis. And how do we achieve it? Basically, in this, the X-ray tube is not static. It moves in an arc like this and produces several low-dose images, and which are then projected and reconstructed into 1 millimeter slices. So now I'll come to the clinical examples of how tomosynthesis has been helping us. So this has been the first advance after the mammogram was made digital. So in this case, you can see it's a dense breast. There is something here, but it is so much better seen with the tomo slice. You can see that the superimposing structures are now not there, and you clearly see the spiculations and the mass here. Another patient. Just, yeah. So again, this area is hidden without tomosynthesis and well seen on tomo. Same area, even on a retrospective thing, I can't see it. So definitely tomosynthesis has brought this finding into focus. I can go on and on actually. Better characterization of margins and improvement in seeing the lesion, even detection as well as characterization. Another case here in which this small octopus-like lesion was seen only on tomo, and then we saw the correlate on ultrasound as well, a 9 millimeter cancer. Then even in the diagnosed cases where you already know that there is a big mass lying within the breast, when you do tomo, sometimes you realize that the extent is much more. So accurate extent and the size is better on tomosynthesis. So this is the additional lesion which was picked up due to tomosynthesis. And sometimes what looks like a lesion, for example, here in the 2D image, it looks like a very spiculated, irregular lesion. And you would probably, recall the patient if she was a screening patient. But if you have done tomosynthesis at the same time, you can make out that this image, this appearance is due to superimposition of crisscrossing structures, which have led to this appearance. So this is nothing but a false alarm on the 2D image. So not only increasing the detection of cancer, improving the characterization, it also reduces the recall rate. So the goals of tomosynthesis are very different in the screening setting and in the diagnostic setting. I would say that tomosynthesis is much, much more useful in the screening setting because it significantly finds 40% more invasive cancers than just doing 2D mammograms. And it also enables a reduced recall rate significantly. However, in the diagnostic setting, the benefit we get is more in the focal asymmetries, in the architectural distortions, as you can see by the numbers, that these are the areas where tomosynthesis might show us an underlying mass or the abnormality more clearly. And then you can get an accurate size and extent, and of course, also identify additional foci of malignancy. But if we are majorly into a diagnostic setting, ultrasound does perform very well for all these functions. So if we are dealing with palpable masses, I don't think tomosynthesis per se adds too much. It is more helpful in the screening setting. So now we know that in spite of having tomosynthesis, there are some cancers which are hard to see on mammography. And here are the examples. the invasive lobular cancer, if the DCIS is not calcified, if the mass doesn't have speculation, it is small, the architectural distortion is very subtle, or it's just a focal asymmetry, or it's a very well circumscribed mass, which is of the same density as the parenchyma, you may not be able to perceive it on mammography. The reason being that mammo or tomosynthesis, they recognize an abnormal area, a cancer, only when it will produce a significant alteration in the morphology. So this is morphology-based imaging, mammography or ultrasound or tomosynthesis. But what about adding a functional component? If we could somehow combine intravenous contrast and mammography, so the thought came that it may enhance the cancers which would otherwise be mammographically occult, and the density of the mammogram will not come in your way. So this brought forward the possibility of having a contrast enhanced mammo, for which most essential thing is that the contrast agent should be visualized on the mammogram. And how is it made possible? By having a dual energy approach. So we all know about the dual energy CTs now. So similarly, we have dual energy mammography. So what that does is that once you, so here is low energy, which is the usual way. Usually we take low energy X-rays for mammography, right? So you can see that if we only take low energy, there is no difference in the appearance between a low energy pre-contrast and a low energy post-contrast. That means the low energy is not sensitive enough to detect the contrast. So what is required? We take a high energy post injection. So now also you cannot see the contrast on the high energy post injection until you recombine these images or subtract. So this is the subtracted image, and here you can beautifully see the iodine part, which means the contrast which is in this mass, which was not seen here, right? You can't see the mass. There is a clip because it has been biopsied, but because of the density of the breast, you really can't see the mass. And the contrast enhanced image, the subtracted image, is beautifully showing you the mass. So this is the further advancement. So I would say that now we are in this era of contrast enhanced mammography. So the low energy images are same as standard mammography, and the high energy images are those which are obtained at high kV. So typically what happens in a bilateral breast examination with two views when you do a contrast enhanced mammography is that first you give the contrast medium injection, and then the breast is put in the compression, and then whichever breast is having the symptom or you're more interested in is taken first, and you do the low and high energy images combination. It gets done with a single click. Then after that, you will decompress the breast, compress again, and take the CC views. So this whole thing takes about 6 minutes, and along with the entire coming in to going out time is about 10 minutes. So in fact, you even have time to take a delayed image if you do want to assess the washout or you want to look for any delayed enhancement. So what are the potential indications? Virtually they are same as that of MRI. Only thing is that a lot of work is going on to validate where contrast enhanced mammo is performing as well as MRI, and where MRI would have a slight edge over contrast enhanced mammography. So virtually in dense breast, in staging, in problem solving, differentiating a scar from recurrent tumor, or even high risk screening for cancer. Now we have a lot of data which is guiding us and is singing praises of contrast enhanced mammogram as a poor man's MRI, because it is much cheaper There's no claustrophobia, and it is done as an extension of the mammography. In the same suit, you don't have to schedule it separately. So a lot of advantages with contrast enhanced mammography. Firstly, in dense breast, you can see that in ACR decomposition of the breast, virtually this mass would not have been picked up if it was not for contrast enhanced mammography. Another patient with a dense and very complex architecture, and this is for screening. So in our institution, we are doing a project on screening of dense breasts with contrast enhanced mammography. And you can see that actually two masses are hiding in this dense breast. One is here and one is here. So these are findings because of the complex architecture of the breast parenchyma, even though it is lying in a fatty part, but it wouldn't have been appreciated. In the screening mammogram, another patient from our project, here is a cancer detected because of the contrast enhanced mammography. Malignant axillary lymphadenopathy proved on biopsy and very, very dense breast. Occult cancer is seen only on contrast enhanced mammography. Disease extent, again, you can only make out this mass, but when you give contrast, you realize that there are smaller lesions close to the index mass. So the extent is much more than what is shown on the mammogram itself. Another patient in which you can see this is a screening patient with a malignant mass in the axillary tail, and this area doesn't look good, but even tomosynthesis is not able to show us a mass as such. But the moment we give contrast, we can see the second mass, which is in fact bigger than the index mass. So additional disease hiding within the breast is easily shown, and then this is very obvious to the surgeon. You can see just the contrast enhanced abnormalities without any background parenchyma. So as I said, that wherever MRI is used, you can use contrast enhanced mammography. For example, when you want to assess the response to chemotherapy, again, you can use contrast enhanced mammography and you can see significant reduction in the enhancement and the size of this mass. Now, this is a very interesting case which was published in Iran Journal of Radiology, in which there were two masses side by side. And these are the two masses. One looks like a fibroadenoma and one looks rather suspicious with very irregular shape and margins. And you can see that the contrast enhanced mammo showed only the enhancement in the cancer, and the fibroadenoma was not enhancing at all. So it could differentiate benign from malignant very well. And in fact, it is found that contrast enhanced mammograms have lower false positive rate than MRI. So this was a case of concurrent and co-located invasive cancer and a fibroadenoma. In this patient, recurrence was suspected, but a contrast enhanced mammo shows us that there is no abnormal enhancement, and this is just a very dense shrunken scar which is looking like a spiculated mass. Post-mastectomy surveillance can also be done with contrast enhanced mammogram, because it is believed that patient who has had breast cancer is at a moderate risk for cancer in the contralateral breast, and that is why we keep screening them. And here you can see that there is cancer which is hiding in this complex kind of breast, and this which wouldn't have been picked up if we hadn't done the contrast enhanced mammography. And when MRI is contraindicated, surely, as in this patient with pacemaker who had a large tumor which underwent chemotherapy. So both pre and post chemotherapy evaluation was made much easier due to the availability of contrast enhanced mammography. So CEDM versus MRI, I will say that it presents most of the times the contrast enhanced mammography it scores over MRI in terms of ease and equipment in cost, in the procedure time, and the fact that you can see the microcalcifications along with the enhancing mass. So you get the entire extent of disease in one view. The only thing where CEM is lagging behind MRI is the conspicuity of lesions. The lesions may not be as conspicuously seen as they are on MRI, because MRI does have a better contrast resolution. And secondly, with MRI, you can have a multiplanar capability, and you can show lesions in the coronal plane, which the surgeons really like, because we are able to give them the extent of disease in terms of o'clock very precisely. So whenever BCS is being planned and you think that this will come in handy, I prefer MRI over contrast enhanced mammography. So you can see here that significantly, it is virtually quite similar, the appearance in this mammogram as well in this MRI and the contrast enhanced mammography. But the conspicuity, of course, is better with MRI. So another patient in which you can see that here was the index mass shown on the contrast enhanced mammo, and here is some non-mass enhancement. And same findings are corroborated in the MRI as well. So still there are false positives on contrast enhanced mammography. Fibroadenomas may enhance, usually not as much as cancer. Radial scars can enhance, and PASH. This is a patient with PASH, and you can see the stippled enhancement. So at times, tomosynthesis may not be so convincing, but the moment you have contrast injection, you can see the lesion shining. So definitely, because it's adding a functional component, CEDM has an edge over tomosynthesis. Again, this is a dense breast. So tomosynthesis will make maybe a 20% difference in the conspicuity of the lesion, but contrast enhanced mammography, by subtracting the background parenchyma, completely shows you the abnormality, and the size measurement is best done on contrast enhanced mammogram. More examples. So now let me say what is next. So until now, we are playing with the new toy of contrast enhanced mammography and trying to see how it's going to help us in our Indian clinical scenario. The next which we may look forward to is breast specific gamma imaging, in which System B is injected. So it is a radio tracer, and then you again get a contrast enhanced mammo-like image. So this will not be, this is also not affected by the density of the breast, but the only con to this type of imaging is the radiation dose. It is quite a high radiation dose, and that is what has been prohibiting the use of this modality. So next is a cone beam breast CT. So this is a kind of a dedicated CT scanner only for the breast. So this is the table, and you have a hole like this, in which, just like in the mammogram, in the MRI, the patient lies prone and the breast is situated within this. And in fact, now even add-on biopsy device has come. So if there is a lesion which is only seen on the CT, you can biopsy it through the same modality. And in fact, the contrast and spatial resolution is so good that you don't have to give contrast most of the times. Even in a non-contrast setting, you can see the abnormalities, and it's just a 10-second scan time, much fewer images than in the MRI. And it's a 3D isotropic volume image of the breast. So that means that you can see that the resolution of the image is same whether I'm seeing it in the sagittal, in the axial, or in the coronal view, or I'm then able to make also a 3D model of the breast. So this is a very good modality. The technology is now so advanced that the dose is comparable to a mammogram. So it's not that we are looking at a very high radiation dose, and you don't have to give contrast, but only thing is the cost is quite prohibitive. These people had come to the institute, and the cost currently is 6 to 7 crores for, so it can only be afforded in places where there is a high throughput. And in fact, you don't need to do a mammogram at all. You can just replace it with cone beam breast CT, and it is touted as one stop shop because you will be doing the three-dimensional kind of a study, and no contrast is required, very short acquisition time, and even the learning curve is very steep because everybody is used to reading CT images. So I think I will leave you with this latest advance, which we should be in future able to use, and I'm very much looking forward to it because it seems to have all the advantages. Thank you.
Thank you, ma'am, for the excellent insights on this topic. So now we'll move towards the next session, which will be on MRI breast. For the next session, we have Dr. Jyoti Arora with us. She is lead radiologist, lead consultant of breast imaging at Apollo Hospital, Delhi. Over to you, Dr. Jyoti. Please unmute yourself. You are on mute mode.
Good evening, everyone. Thank you for giving me this opportunity to talk on breast MRI. Is my slide visible?
Yes, but please, yeah. On the slideshow mode. Yeah, it is visible.
Okay. So today I'm going to talk about breast MRI from detection to diagnosis to decision making. So I'll be talking less about detection and diagnosis because that goes in the kitty of the radiologist, and decision making, I think that is what most of the surgeons would be concerned about. And I know there is a popular belief that with MRI, it leads to more of mastectomies, more of biopsies, as compared to the conventional imaging, that is the mammo and the ultrasound. So, so the detection, when we come to detection of the tumor, it's basically we have to see any enhancing lesion. So detection becomes easy, the detection of the abnormality. The only thing that we have to see is that the quality of the scan should be good. It should be at least a 1.5 Tesla should be done in a breast coil, and the contrast that is injected is through a power injector and not handheld injections, and should be done for the right indication. For example, if it is for microcalcifications, then there may be low-grade DCIS which may not show up on the breast MR. So if it is microcalc, the first thing we have to do is biopsy. MR would not replace biopsy. So it should be done for the right indication, and the quality of the scan should be good. Then it's very easy to detect any abnormality on the MRI. The second step comes is diagnosis. So we have various features. We have a whole lexicon where we talk about the morphology and the kinetics of the lesions, which help us to say some of them we can characterize completely as benign, some of them highly suspicious, and then there would be few which would be in the Barrett's 3 category, which would be requiring follow-ups. So again, a lesion like a focus, it will all depend why is the scan being done? If it is like a problem solving and I see a focus in the opposite breast, I might just ignore it. But if it is being done for a nipple discharge, the tiny little focus might be a papilloma. And if it is being done as a pre-operative staging scan, that and it is very close to the index lesion, it might be a satellite nodule. So indication should be known, and that would change your diagnosis. And then once you have made up your mind that, whether it's more likely to be benign or more likely to be malignant, then depending on your level of suspicion, we need to biopsy, and one needs to be very good at second look ultrasound. And in fact, more and more lesions are nowadays being picked up on second look ultrasound because of the high-end ultrasound machines that we have. And Dr. Palak showed so many cases where she picked up abnormalities on second look ultrasound. But if not, and if the lesion is suspicious, we go ahead with the MR guided biopsies. Now comes the important, that is decision making. Based on our detection and diagnosis, we do our decision making. In fact, because of the MR, what we are seeing is, contrary to the popular belief, we have been able to have the confidence for going for wider resections with oncoplasty surgery rather than going for MRM. And I'll show you a lot of those cases in the following slides. So this was a patient with right breast lump, proven malignant. You can see very dense mammogram, and this was the lesion seen on the ultrasound. So obviously it needed an MR to be sure that we are not missing anything extra. So here, again, the background enhancement was marked background enhancement, but we can be confident that there is this lesion. Can my arrow be seen or no?
Yes, it is seen. It is seen.
So this is a lesion. There's possibly a small satellite nodule. So I'm not going to do a biopsy of this tiny little nodule. I'll just tell my surgeon that they just need to go a little bit extra anteriorly so that even if it is a real satellite nodule, it gets removed. But it can very well be a benign breast change. But I'm not going to go and biopsy this. I would just let my surgeon know that they just need to be doing a little bit wider excision anteriorly. Another case of left breast cancer. So when we did the MR, in addition to the main lesion, there was another lesion slightly. You can see we would not call this as a satellite. It's bigger than a centimeter and a little away, more than 1 centimeter away from the main lesion. So here so what we did, and this had lymph nodes positive. So the plan was to give neoadjuvant chemotherapy for this patient. So what we did, we clipped the main lesion, we clipped the second lesion. Both of them were now proven to be malignant. So we did the biopsy of the second lesion, and then we placed the clips in both the lesions. So here you can see both the lesions were clipped. Post NACT, there was significant reduction in the sizes. So because of the high negative value of the MR, we were quite confident these are the only two lesions. And we did a wider resection, removing both the clips out with good radiological margins. And obviously, that gap had to be filled up with oncoplasty. Another patient, she was a screening mammogram that was done, and I could see a new focal asymmetry in the upper half of the right breast, just above the implant on the mammogram. This was new, so did an ultrasound, and here you can see an irregular lesion just at the superior aspect of the implant. And on the MR here again, you can see on the in the upper half there was this small little enhancing mass which corresponded to the biopsy proven cancer. So in addition to that main lesion, there was another small little enhancing nodule that I could see at the lateral aspect of the implant. So I went back again and I could see that subtle area of low echogenicity along the lateral aspect of the implant. I biopsied this as well, and this turned out to be another cancer. So obviously now it is multicentric, not multifocality. But because of the confidence, earlier if we're getting multicentric disease, it was always used to be MRM, but now because we have the MR, and if we get that confidence, it has a very high negative value, so we know these are the only two lesions. And if the size of the breast allows, then we can do 2 lumpectomies. We can fill up the gaps wherever needed with oncoplasty, and can still save the breast. In fact, this patient was very keen to save her implants also, which we had done for her. 4 years down the 4 years post-op, she's completely fine, with no evidence of any recurrence. Now, not only do we get diseases, MR picks up ipsilateral tumor foci, but also contralateral diseases as well. So this was a proven case of right breast cancer. And in the contralateral breast, we could see a unique focus. So we went back and did an ultrasound. And here we could see a small lesion. This was proven. This was IDC with neuroendocrine differentiation. So this was biopsy proven to be cancer, and hence it was removed along with the treatment for the index lesion. So contralateral lumpectomy was also done here. Now this patient had 2 cancers, one in the upper outer and the other in upper inner. So there was upper outer quadrant in the left breast and a small little upper inner quadrant or upper central quadrant lesion. Both of them were biopsied. They were proven to be malignant. She had a large lymph nodal mass as well. So she was very keen on breast conservation. We did the ultrasound, did the biopsies, and then we did a MR. On the MR, we could see just these 2 lesions. Obviously, the lymph nodal mass was there, but a small little irregular nodule in the contralateral breast. So this we could not see on the ultrasound. So we did MR guided biopsy for this lesion. So you can see here the main mass, the smaller lesion in the upper inner quadrant, and this small little nodule in the opposite breast. So we did an MR guided. This was proven to be a benign lesion. The other breast, the patient went neoadjuvant chemotherapy for that lesion. They were all clipped and 2 lumpectomies were done for this patient. So again, the confidence to do lumpectomies rather than mastectomy comes from the fact that we have done an MR and there is no other disease apart from these 2 lumps. So here, this patient had locally advanced cancer in the right breast and a tiny little unique focus. There was a lot of background, but this was obviously a unique focus. She was advised an MR guided biopsy for this, which she refused. She said, if chemotherapy will take care of my right side, it will also take care of left side, even if it is a cancer. So she refused. This lesion on the post NACT MR, we could not see it. Patient had an MRM for the right side, but 2 years down the line, she had widespread locally advanced cancer on the contralateral side, which was not tackled at the time of the first surgery because she refused to get an MR guided VAB at that time. So here you can see she was all fine from her previous surgery. The right MRM was there, but now there was cancer on the opposite side. So this patient had Paget's of the left side. Usually Paget's are associated with DCIS or IDC in the same breast. So to see that, we did an MR, and here we could just see nipple enhancement and thickening, but there was a contralateral small little focus in the right breast. So this patient second look ultrasound was done and biopsy proven cancer on the contralateral side. So she had a central excision on the left and a wide local excision for the right side. This was again an ill-defined lump, but it can be very hard at times on conventional imaging. On ultrasound, it was just showing shadowing. Was proven to be cancer, but MR gives you the exact extent of the disease. If it would have gone for on ultrasound and palpable abnormality, the lesion was appearing smaller. But if it would have gone for a lumpectomy, this patient would have definitely got positive margins. Similarly, this was a case of small area of microcalcifications, which were proven to be high-grade DCIS on stereotactic biopsy. Because it was high-grade DCIS, there is always a chance that calcifications may be just the tip of the iceberg, and that was exactly in this case also. When we did an MR, you can see there was a large area of segmental non-mass enhancement. This whole area was high-grade DCIS, so she again went for MRM, but I think if she would have gone for lumpectomy, then that would have led to positive margins again. This patient had a very strong family history. She had a biopsy-proven right breast cancer. On the MR, there was associated non-mass enhancement. She was advised MR-guided biopsy for this, which she refused. She said, anyways, she would like to go for a mastectomy. But this came out to be benign breast changes. I thought this would come out as DCIS, but this really... we need to stress upon decision making can be wrong if we just presume that whatever we are seeing, the enhancing areas that we are seeing on the MR are malignant only, and they can very well be benign but may look like malignant lesions. So biopsy is a must before changing any management. This was again a patient of right breast cancer. On the when the MR was done, we could see a segmental non-mass enhancement on the opposite side. This was again biopsied, MR guided, and this came back as DCIS. So anything that you see in addition to the main, unless you can sort of, you don't have to really change the management, maybe a little bit wider lesion is all that is, resection is all that's required. You have to prove it with the biopsy that this lesion is definitely malignant before changing the management. Now, this patient was a case of left breast cancer, very dense breast. When the MR was done, solitary lesion on the left side, but on the right side, we could see this non-mass linear enhancement, which was clumped. MR-guided biopsy was done, and this came back as periductal mastitis. Another thing that I wanted to imply was it's very important to know the indication, and that can change the management at times. For example, in this case, there was a bloody nipple discharge, and we could see on the ultrasound as well as on the MR, small intraductal lesion, which was very close to the nipple. You can see the nipple here, and here we have this intraductal lesion. So she was because this is very close to the nipple, there is a high chance this is just a papilloma, but worse come to worse, it can be papilloma with atypia or DCIS. So these tiny little lesions either can be removed with VAB in the younger age group, but because she was a 64-year-old, a major duct excision can be done even without doing a biopsy, because many a times we have seen if it is a 2 to 3 millimeter or 5 millimeter lesions, many a times pathologist, even though you hit it, pathologist might find it difficult to confirm whether this is a papilloma or not. But if it is an intraductal lesion which is linear, then the chances of it coming back as DCIS or IDC become very high. And if it is away from the nipple, then again the chances are high. In those cases, I always like to do a biopsy. Even if I have to go for an MR guided, I would do a biopsy before asking my surgeon to go for the surgery. But in such cases where it is very close to the nipple, it is definitely likely to be on the major duct excision. And also in this case, it was you can literally see it is filled with the duct is filled with blood. So as soon as they go for the surgery, they can literally feel these kind of ducts. So this is likely the removal of this kind of lesion is very, chances of its removal will be nearly 99 to 100%. But a lesion like this, where it's a linear branching kind of a lesion, again nipple discharge, and it is quite far away from the nipple. So when the surgeons would be doing major duct excision, it is usually for the first 4-5 centimeters, but this is quite far away. So even if they are doing like a therapeutic and diagnostic major excision, these papillomas can be left behind, which may turn into something nasty later on. So such cases should always be biopsied before any decision regarding surgery is made. A similar patient, this lady, postmenopausal female, she came with a history that she had nipple discharge, for which a major duct excision was done. There was nothing except for the benign changes. No papilloma was seen on the final histopathology. That was somewhere 5 years back. And she said after that, she could feel lumpiness in her left breast in the inner half since the surgery, and it has been increasing. The lumpiness has been increasing. In fact, in those 5 years, she had 7 FNACs and all of them had come back as negative. So when I did the ultrasound exactly in the area of where she could feel, I could see a little bit of duct prominence, and it looked like it was a cyst with the internal echoes. There was no vascularity that I could see on the ultrasound. But when I did an ultrasound, again, you can see there's a lot of benign breast changes or marked background enhancement. But this area, if you see on the MIP, that was the area of palpable abnormality. There are multiple enhancing foci which are clustered together or clumped together. So this was definitely worrying, most likely because the major duct excision was done. So she was relieved of her symptoms, but no papilloma was removed, and it went on increasing in size. So here, because we could see something on the ultrasound, so we did a vacuum assisted biopsy here, and this was proven to be DCIS with microinvasion. So I would not talk much about the diagnostic criteria for cancers, but words like irregular shape, indistinct, irregular, speculate margins, rim or heterogeneous enhancement, these are all worrying lexicons that would warrant a biopsy. And again, type 3 curves, early enhancement, washout or plateau phenomena, these are again worrying, which might indicate malignant lesions. So biopsy is warranted in these cases. When it comes to non-mass enhancement, we need to be particularly important because most of the times we don't see them on ultrasound. So any linear clumped enhancement, that is worrying. So here we had the linear branching. This is again worrying, and segmental with clustered ring patterns. These are the worrying patterns that definitely would be needing biopsy. The rest of the patterns would depend what was the indication for which the scan was done and whether there is any correlate on the ultrasound or on the mammogram, whether we can follow it up or we need a biopsy to be done. Focus is another important lesion on the MR, and it will always depend on what kind of a indication for which the MR has been done, and that will decide whether we would be just following it up or whether we need to do a biopsy. So this was a focus, but here the patient had nipple discharge. So that's why the biopsy was done. It was away from the nipple. This came back as papilloma. This is the same case. So if it is a unique focus in a known case of uh, cancer, then that becomes important. This was a small focus, but it's very close to the blood vessels in the upper outer quadrant. And here you can see it has a reniform shape. So this is a very typical site for the intramammary node. This didn't had any warring features or any warring indication. We can see a small little fat at the hilum here. So this focus we know we will just give it a 2 there. This was a patient of left axillary lymph nodal mass, which was biopsied and proven to be cancer. And here we had multiple tiny little foci. So these, although multiple foci, we would not worry about, but if they are clustered together and we have, already biopsy proven lymph nodal mass, which is metastatic, then these foci definitely become important. This was biopsied, not seen on ultrasound. This came back as invasive lobular. Another feature is the background enhancement, and that at time can mask non-mass enhancement or even smaller masses, which one should be aware of to help your detection or diagnosis of a real abnormality. So this was an asymmetric non-mass enhancement. Looks worrying, but this was just a background enhancement, which was more on the left side. This was a biopsy proven fibroadenoma. This was stable for more than 3 years. This also looked like an asymmetric background enhancement, but always remember background enhancement or the parenchymal enhancement is always seen along the outer and the posterior aspect. So these are more commonly seen in the upper outer, and these are very rarely seen in the inner half. So here, this the enhancement in the inner half is not at all normal. And here it was again a biopsy proven case of left breast cancer, and this was a cancer here, and it was associated with a non-mass enhancement along with the mass, which was mimicking like a asymmetric background enhancement. This again looked like a asymmetric. So here you can see upper, outer, and posteriorly. So this is picture framing. This kind of a background enhancement is normal, but here you can also see it in the inner half. So this is not asymmetric. Here we had again a mass which is on the MIP images looking like an asymmetric enhancement. So this was the mass. So it was already known, biopsy proven, but if you just see the MIP, you might think it's an asymmetric background enhancement. Now here, again, for our diagnosis and detection, there are now newer sequences like ultrafast. Diffusion weighted always used to help, but it is not that helpful when it comes to very tiny lesions. So here, this patient had left breast CA and an MR was done here. And here you can see a unique focus. So when we introduced, that was the time when recently had introduced ultrafast sequences. So here you can see the contrast is just entering into the descending aorta. And so here we have just the main mass coming up, but this was 6 seconds after the contrast was seen in the aorta. And here you can see the small little focus enhancing, and this was about 12 seconds. So if the enhancing lesions can be seen within 10 seconds of contrast in the aorta, then they are likely to be worrisome. They definitely require then biopsy. So because this was showing such early enhancement within 10 seconds of contrast being in the aorta, so this was something that had to be tackled. We went back to the ultrasound. Luckily, we could see here an irregular nodule. This was hardly 2 to 3 millimeters, and this was biopsied, proven to be atypical papilloma, and this was removed along with the main lesion on the opposite side. The other thing that I was talking about is the technique and the indication for which the breast MRs are done. So, hormonal enhancement, whether the patient is on HRT, whether patient is in the right phase. Although we don't nowadays wait for the right period, but it's important to know if there is a lot of background enhancement. Is it because she's not in the right phase, or is it because she's taking HRT? But more importantly, if it is a case of invasive lobular or a low-grade DCIS, even mucinous can many a times mimic like just a benign and small rim enhancement, or there may not be much enhancement. So these are the tumor types where MR may not be as sensitive as in the other cases. So here again, why I keep asking my surgeons that I can't report on films, I need a CD. So technique again is very important. So here you can see there are multiple enhancing foci, and they all look like benign breast changes. This patient had a nipple discharge. And if I don't have a CD, I can't reconstruct these kind of images. So here you can see on the subtracted images, this was the tiny little focus which is in the duct. So this was an intraductal papilloma, but I can be sure that out of all these enhancing foci, which is the one which is the culprit, is only if I have the multi-planar capabilities, for which I always need the raw images, the CD, and I can't comment on the films. So technique again becomes very important, and to get the whole spectrum of the images is very important. This again was the same tiny little focus, not commented, but when I sort of made that oblique images, then I could see this is right along the duct. So this was the lesion, linear enhancement. It turned out to be a papilloma, which was causing bloody nipple discharge. But if you see on the axial, it will just appear as a tiny little dot and can be easily missed there. So this is my last case, and this really sums up what I'm trying to say, that with the MR, the confidence that we are getting to convert MRMs into wider local excision with oncoplasty is because of its higher negative value. So this patient, a very young patient, she had at least 15, and out of this, 5 or 6 I could see when I did her ultrasound. I could see 5 or 6. If it would not have been an MR, I would have straight away asked my surgeons to go for a MRM. So here she had a lesion at 2 o'clock, which was palpable. And these all were seen on imaging. The rest of the lesions were seen on the imaging. So we biopsied 2 of them. They were proven to be cancers. But we had the confidence to give her a wider local excision with oncoplasty reconstruction, because what I did was, this was at 2 o'clock, this was palpable, the inferior most was at 4 o'clock, so I had put a wire at 4 o'clock. This was palpable. The medial most was very close to the nipple, so that became the medial most extent, and the lateral extent was already a palpable lesion. So this is what we had done, had put the wire for the 4 o'clock lesion. This was the palpable lesion, and here the nipple became the medial most extent for this patient. So the oncoplasty reconstruction could be done, and we could save patient's breast, and rather than doing an MRM. So with that, I would like to conclude the take-home message. When we are reporting MR, the technique and doing the MR for the right indications is very important. Always remember, for low-grade DCIS, for invasive lobulars, the detection can be difficult. Ultrafast sequences, diffusion, they really help us in building up our confidence when diagnosing cancers. And again, the lesions picked up will depend for what reason the scan has been done. So you can confidently triage them into benign, malignant, or intermediate. And always do a biopsy before changing your management. High negative predictive values of the MR, and with the oncoplastic procedures that are now being done, they are allowing more and more conservative surgeries in multifocal, multicentric diseases, which on conventional imaging, they would have been candidates for MRM. Thank you.
Thank you, Dr. Jyoti. It is always a pleasure listening to you. So without wasting much of time, we'll move to the next session. And before that, Dr. D.G. Vijay sir has also joined. Good evening, sir, and welcome. My request to all the delegates to please put their questions in the QA box so that we can discuss it after all the sessions are over. So for the next session, we will discuss the role of BIRADS, which has come actually a long way to have a better and deeper understanding of the clinical implications. Let us listen to our next speaker, Dr. Madhavi Chandra. Ma'am is a senior consultant and co-chairperson in Department of Radiology at Sir Ganga Ram Hospital. Over to you, ma'am.
Thank you so much, Dr. Prekshi and all organizers. I'm in an area where my internet is not very stable. So if you can't hear me or see the slides at any point in the middle, please let me know and I'll switch off my video and speak without it. That will ease up on the bandwidth. So I'm going to be speaking about evolution of BIRADS classification and its clinical implications. So we start with a little bit of totally irrelevant history, but which led to the development of BIRADS. So, the US about half a century ago was pretty much where we are now, with people not going for mammograms, hating mammograms, saying that there's pain, there's radiation, and just refusing to have mammograms. Then what changed it was this. The First Lady of the United States, Betty Ford, got breast cancer and was very open about it. This is her in the Naval Hospital at Bethesda, immediately after her mastectomy. And you can see how on the side that she's had the mastectomy, she's throwing a soccer ball to the president, and there are all the doctors. So this really increased visibility, and everyone was like, if the First Lady can get it, then so can I. And she spoke so much about how early detection made a difference to the diagnosis and the prognosis. Plus, it increased funding for research in mammography. Then the next thing that happened was that in 1982, this lady, Nancy Goodman Brinker, lost her sister at the age of 36 to breast cancer. Now that affected her tremendously, and she said that if I knew more about breast cancer and early detection, we would definitely have gone and had a mammogram earlier. And she started these runs for breast cancer. And you can see that logo, that these Susan Goodman Komen for the Cure Foundation runs, which are now held in multiple cities and raise millions of dollars every year for breast cancer research and cure. That's where the pink ribbon for breast cancer comes from. And then another First Lady in 1987, Nancy Reagan, got breast cancer, and also this increased awareness. So from a stage over roughly 1.5 decades where there was hardly any mammography or any research into mammography in the United States, there was huge public funding and huge research and huge number of women getting mammograms. So this increased the number of mammograms, this increased screen detection, and this decreased mortality due to breast cancer. There was a clear correlate. So the conversation switched from diagnosis at this horrible stage, which is even now very visible in India, to these tiny screen detected cancers. This is only a 4 mm cancer, which was easily picked up on mammography with tomosynthesis. However, the clinicians were not happy. In the 1980s, the American Medical Association, full of physicians and surgeons, said that mammography reports too often contain unintelligible descriptions and ambiguous recommendations. So did we like that? Did the radiologists like that coming from the clinicians? Not at all. So the American College of Radiology decided to do something about it. But this is also the stage that India very frequently is at now. So this is a report which is not so many years ago from Delhi itself, where the impression is hyperdensity lesions in both breasts. Now, what are those hyperdensity lesions? Nobody knows. It just says that maybe do an ultrasound and correlate clinically. So, if the patient has gone with a lump and you still have to just do a clinical correlation, the surgeon or the physician is not going to be happy at all. At the end of that investigation, nothing is being diagnosed because it could be a benign lesion or a malignant lesion. Nobody knows whether it's probably benign or probably malignant. And then you have other reports which come in with BIRADS 3 to 4, BIRADS 4A to 4B. So you have terrible reports which don't communicate anything to the clinicians. We must remember that imaging is not simply taking an image. It is helping towards diagnosis and management. We are not photographers, we are doctors. So we needed mammography reports that needed to be concise, clear, and the most important thing, directed at management. So in 1986, the American College of Radiology convened a committee of radiologists, medical physicists, and FDA representatives to develop a mammography accreditation program and recognize that we needed meaningful descriptors which helped us in correct diagnosis and also correct communication. So also in this, also the people who came on board to develop this breast imaging reporting and data system were the American College of Surgeons, the College of American Pathologists, American Medical Association, National Cancer Institute, and the Center of Disease Control and Prevention. So large base of stakeholders, and hence lots of inputs, lots of data sharing. And what is it that is needed from radiologists was very clearly communicated. And so this was a dictionary. A lexicon is nothing but a dictionary for a language that was developed by the American College of Radiology to standardize the description and management of findings identified on mammograms. And everyone knew what those words meant, and thus it facilitated communication between radiologists and referring physicians. Now, these are the first three BIRADS editions. The first was just a folio like this and was released in 1993, and then second in 95, and then 98. All these three had only mammography, recommendations for the conduct of imaging, overall structure for reports, and final assessment categories with management recommendations, and of course, a mammography lexicon. In the fourth edition, which was released in 2003, was ultrasound and MRI. So this was the fourth edition for mammography, but the first for ultrasound and MR. And in each edition, the number of images and the number of descriptions and content increased. Plus, there was an audit. So we will talk more about the audit later. Now, what were these descriptions? All these descriptions or the describing words for various findings have positive predictive values or negative predictive values for malignancy. And the worst feature determined the BIRADS assessment category. So the positive predictive value is really the chance of malignancy that a finding with its descriptors indicates. Now, what does this mean? That means that if we are talking, say, about speculated margins, which has a PPV of 81%, that means that, say, you've seen 100 masses with speculated margins, 81 of them are likely to be malignant, and 19 of them are likely to be benign. So that, in very simple terms, is what positive predictive value for malignancy is. So that made it very simple. Now, if you have large databases, they went into databases of hundreds and thousands of women, because these large screening programs that started in the 80s had lots of enrollment, and we had studies with millions of women, and hence this data could be figured out that if there's speculated margins, what are the chances of malignancy? If the shape is irregular, what are the chances of malignancy? And so it could be classified, and the chances of malignancy worked out, and appropriate management recommended. There was also a report organization format, which is more important for the radiologists, but makes it easier for the surgeons, the physicians also to understand the report, because in every report, there's an indication for examination. You do put down the history, you put down the kind of cancer, if the patient has had a cancer earlier. There's a description of the overall breast composition, any important findings with their descriptors, any comparison to priors, and finally, the most important, the assessment category and the management. So the descriptors, for example, now I'm not going to go through all of BIRADS, that's for radiologists, but the different types of shapes. Let's take irregular. So this indicates an irregular shape normally indicates non-uniformity of growth. So that is more likely to be malignant. And it was found that, yes, when you look at, say, 100 irregular masses, about 73 would be malignant. So that's a PPV of 73%. When we come to the BIRADS assessment category, 73% goes into BIRADS 4C, highly suspicious of malignancy. You add these microcalcifications, and then you go into BIRADS 5. So this is how, by using these descriptors, radiologists classify findings into certain assessment categories. Similarly, mass margins have different positive predictive values. I've already told you about speculated having an 81% PPV. And that is because speculations are usually caused by invasion of the surrounding tissue and desmoplasia in the surrounding tissue. So a radiologist is very certain, or looks at the fact that there's a high possibility that the mass, if irregular with speculated margins, may be malignant. Another thing may be high density, which again, more than half of the masses may be malignant. So similarly, now for negative predictive value, if a mass has fat, then the chances of it being malignant are very low. 95% of all masses with fat inside them would be benign. However, now with tomosynthesis, you do have some cancers that entrap fat. So you have to be careful and look at everything in conjunction. And remember that the worst feature will determine your BIRADS assessment category. So again, in calcification, it depends on morphology, it depends on distribution, and your radiologist is the best person to look at the calcification, to look at the morphology. If the person says that the calcification is clearly benign and gives a BIRADS 2, the radiologist is giving a BIRADS 2. If, for example, post-surgical, this is dystrophic, there's rim calcification, all these are classically benign and will just be given a BIRADS 2 assessment. You don't have to do anything about them. Suspicious morphology, if the radiologist says 4A or 4B, then you have to definitely, biopsy. For example, in this case, the calcification itself is a benign sort of calcification, but the distribution works against it because it's linear, which may be in a duct. So the PPV, the chances of malignancy go up to as much as 88%. So definitely BIRADS 4C, and this should be biopsied, and this was biopsied despite its very posterior location. And this turned out to be DCIS. And amorphous has a lower PPV, but still you must remember that even if 20 out of 100 masses with amorphous calcification are going to turn out to be malignant, you have to biopsy it. And remember that in this case, we also have associated architectural distortion, etc. So everything works together to give you the final assessment category. This is a case, for example, where the calcification is coarse heterogeneous, which has a PPV of 15%, but the distribution, that is, the calcification is all grouped together. There are multiple calcific specks within a small 1 centimeter square area. So that increases it to 37%. So it goes to the higher end of BIRADS 4B assessment category. And this, if you look at just the fine pleomorphic calcification, which is 29%, and group 18 to 37%, you would say it's somewhere in 4B But of course, you have to see that there's this huge fungating mass, so you're not going to ignore that obviously and just go with the calcification. So this is a BIRADS 5 finding. This, however, would be a 4B finding where there's only the fine pleomorphic microcalcification with no mass. So, when we get all these findings together, like I've been saying, like here we have segmental, fine pleomorphic, terrible looking calcifications, there's architectural distortion. This is all by RADS 5, that mass with associated fine linear and fine linear branching calcifications. It's high density, it's irregular, the margins are speculated. So this is 5. This is fine linear branching calcifications. That's 4C. And this is just pure architectural distortion. Now, the PPV can be up to 75%. Sometimes things like lucencies in the center can reduce our, because this is a classical complex sclerosing lesion. So this is BIRADS 4B. So all you have to remember is that your radiologist is looking at these multiple findings, assessing all the descriptors, and figuring out which BIRADS assessment category they go into. Similarly, on ultrasound, you have mass shape. So again, irregular is the worst. Then orientation, not parallel, is worse than parallel. Not circumscribed margins are worse than circumscribed margins, and so on. You can have simple cysts, nothing to be done. Lipomas, nothing to be done. But then you have complex cystic and solid masses. You have heterogeneous masses, hypoechoic. While a lot can be benign, there can be some triple negative breast cancers, etc., which can be malignant. So you have to take into account the clinical picture. For example, if this mass is a newly palpable mass, even though you may image it and categorize it as BIRADS 3, you would still want to advise biopsy. So the clinical our radiological assessment will still have a different management category. And here is a classical BIRADS 5 mass on ultrasound that's irregular with speculated margins, architectural distortion, microcalcs inside the mass, shadowing, and a little tethering to the skin there. There's an echogenic rind around it. So this is a BIRADS 5 on ultrasound. So these are the BIRADS assessment categories that were developed as the BIRADS, once the BIRADS manual was released. And amongst these categories, 0 to 5 were the first categories that were developed. 6 was added later. So in 0, we have not completed our imaging. We either need to add additional views or maybe do an ultrasound, or we need to compare with prior mammograms to determine what the category is. 1 and 2 are pretty much negative. You don't need to do anything for them. 3 is probably benign. That is a 0 to 2%, up to 2% chance of malignancy. 4 has a large range from 2 to 95%. So that is divided into 2 to 10% low suspicion for malignancy. So if I'm putting something in 4A and I biopsy it, a lot of those lesions will turn out to be benign and I would accept them. So this is where RAD-PATH concordance comes in. So where you have a low suspicion for malignancy, a moderate suspicion for malignancy, and a high suspicion for malignancy, highly suggestive of malignancy. So the 4s and the 5. Now in 4C and 5, if I get a negative biopsy, percutaneous biopsy report, I'm likely to want to repeat that biopsy because there can be sampling errors. And I have a very high, I'm thinking that this is likely malignant. So the radiologist will look at the pathology report. If it's not a mimic of malignancy, the pathology report, then he or she is going to go back and go in again and take a repeat sample or advise a surgical excision in some cases because the findings are discordant. And if it's a moderate suspicion, low suspicion, then it depends on how in 4A you will accept a benign report. In 4B, you are likely again to look at the images again, see whether it can match or not. Then there's actionability in BIRADS. So actionability means how urgently will you address the report. So if it's a BIRADS 5 report, immediate action. So 5 is the highest. 4 again is almost equally high because you want to go in and biopsy that too. 5, of course, you will biopsy immediately. 4 also you will biopsy. 0 also needs to be addressed because it could go either way. It could go to negative benign, but it could also go to 4 or 3. So you do need to address 0. Then 6 is biopsy proven malignancy. This was a category that was added later. And in that, we don't have to do anything else. It goes to the clinician. And then is 3 where we have delayed follow-up. 2 and 1, we have to do nothing. So this is the actionability stratification, and you address it in this order. So this is, of course, where we have fat in the mass, and this is a BIRADS 2 finding, and nothing has to be done. This is BIRADS 3, but like I said earlier, the clinical picture also has to be taken in. If this is a lady over 40, and or even a younger lady where it's a newly palpable mass, you would maybe biopsy it. These are the management recommendations for BIRADS 3, where it's essentially a radiological follow-up. So where there's an ipsilateral 6-month follow-up with the imaging modality best seen, on which the lesion is best seen. And then you do a bilateral 12-month follow-up and a bilateral 24-month follow-up. If at any point the lesion becomes smaller or resolves, you downgrade to 2 and return the patient to annual screening. If it increases in size or volume by more than 20%, then you biopsy. And if it's stable over 24 months, then at the end of 2 years, you would downgrade it. So then BIRADS 4A, B, and C all go to biopsy because the chances of malignancy are enough to deserve a biopsy. And you have to be, of course, careful about RAD-PAP concordance. So this is again, that case where we have BIRADS 4B calcification, and we had an ultrasound correlate biopsied it, and it was ADH. So that matched, and that was excised, and there was DCIS also on excision. And this is a CSL on 4B, which was VAB'd by Smriti. And she did a very good large volume VAB, and this was all benign with no atypia. And I think she's been on follow-up for many years and has been stable. So 4B, we would, especially with that recency in the center, we would accept a benign biopsy report. And here's a 54-year-old female with a right breast lump, and you have that irregular mass with speculation. So the obvious answer to that, what next, is biopsy. There's no other answer. So this is a 4C finding, and we would go to biopsy. Ultrasound, of course, also shows very suspicious findings, and this was an invasive duct carcinoma. In BIRADS 5, your radiologist is going to give this only with very specific findings. It's an irregular speculated high-density mass with associated calcifications or new fine linear and branching calcifications in segmental distribution, and biopsy needs to be always performed. So this is a BIRADS 5 mass. That's how your formal report should read if the radiologist is reporting as per BIRADS. And the management recommendation is biopsy in the absence of clinical contraindication. So this is how the radiologist is going to report, and hopefully it's going to be very clear once the surgeon and the pathologist are familiar with the BIRADS system, that the radiologist, there's a method to the madness. It's not just randomly tossing a BIRADS category or tossing the films and saying, okay, the ones that land on the left are BIRADS. There's a real method. We are looking at the images, we are looking at the descriptors, and we are, assessing and doing the best we can for the surgeons, because again, like I say, this is a clinical system, and RAD-PAP concordance, the pathology report must come back to the radiologist. The radiologist will decide whether the pathology report matches the radiological findings or not, and advise the surgeon whether we want to repeat the biopsy or we would like the surgeon to excise the lesion, and advise the patient also. And we form the hub between the pathologist, the physician, and the patient Now, here also another question that was asked recently was whether surgical, biopsies in the OPD are fine for palpable masses. So no, they are not fine. For example, this is a young patient with a large mass, which we were suspicious about. We'd given it a 4C, and this because there were angular margins. It was a mass with indistinct margins, and at biopsy, this was negative. It said lobular mastitis, even though we'd given it a 4C. So we went in again and we discovered that, part of the mass was not, was a little cystic or necrotic, pseudocystic. And so we went in again and at this point, when we were sure that we were getting the solid component, we managed to get invasive ductal carcinoma. So BIRADS is a system that works. It works best if the surgeon and the radiologist and the pathologist are all on the same page and will, work together. And now we are expecting the 6th edition. So this is where BIRADS is going next, in which there are going to be changes in descriptors and ultrasound, but I think not so much in management criteria, etc. So thank you very much.
Thank you, ma'am. Thank you for the great lecture. So now we'll move towards the next session, which is the QA session. So first question is, MRI shows some additional lesion. Should we alter our surgery plan or we should go ahead with a biopsy? Dr. Jyoti, would you like to take it?
So if you see additional lesions, it all depends what your take, like what BIRADS category you are giving and what was the indication for doing the MR. So if you think it's a definite benign, then nothing needs to be done. It's suppose if you can see a fat within that lesion, then you're pretty sure this is nothing else. If that lesion looks worrying, it's a small focus, it's giving you type 3 curves and it's very close. The reason for doing that MR was for preoperative local staging. And this lesion is very close to the index lesion. Then, although you're not sure whether this is 100% small satellite focus, but you can still tell your surgeons just to be a little bit wider, so that gets included. But if it is away, significantly away, then definitely you have to biopsy that lesion before you alter your management.
Right. Thank you, Dr. Jyoti. So next question is contrast enhanced mammography versus MRI. What is the current evidence for superiority or equivalence? Smriti Hari, ma'am, will you please like to take it?
Is there?
She is there, but probably network issues might be there. So Madhvi, ma'am, CEM versus MRI, what is your choice?
So, earlier it was thought that CEM has a slightly lower sensitivity than MRI. But recently it's been proved that CEM is quite as sensitive as MRI, and as Smriti showed, in some cases more specific. At the same time, MRI has its own benefits. The 3D recons, the sagittal imaging, the absolutely, in fact, Jyoti, you're a great person to take this with me. Uh, so, uh, I mean, like, there's radiation in CM, there's iodinated contrast. So these are some negative things, but there are patients who are claustrophobic, patients with pacemakers. So, but it is much cheaper, much quicker. You're out in 5 to 6 minutes. So there are advantages and disadvantages to everything. What would you say, Jyoti?
So my take is my preference is MR because the lesions are much more conspicuous. In my experience, whenever I have picked up, like you do a mammo, you do an ultrasound, and if you do a good ultrasound with a good machine, the additional lesions that you pick up, they are the ones that are confirmed on contrast enhanced mammo. It is mainly the MR which really picks up more lesion compared to mammo plus ultrasound. And especially the non-mass enhancement, because these tiny little small nodules, they're picked up on ultrasound. Like we have now picked up 3, 4, 5, even without the MR, we pick them up on the ultrasound, and MR is just confirming. Or even if I have not done an ultrasound, have straight away gone for an MR because ultrasound was done outside. The small little lesions, the masses that we pick up, they are mostly seen on ultrasound. It's the non-mass enhancement which is difficult to be picked up on ultrasound, and it's also difficult to and that changes your management. So contrast enhanced mammo is not that great. The conspicuity is not that much when it comes to non-mass enhancement. And whenever ultrasound, like contrast enhanced mammo may show few nodules, but we always see them on the ultrasound also with a good ultrasound. So I still go for contrast enhanced MRI. That's my go-to thing. But if the patient cannot undergo MRI, then obviously it's better to go for a mammo than not doing anything else, especially if it is a dense breast. So
Functional imaging
conspicity is definitely better. And a lot of things, like when you're doing for papillomas, like nipple discharge, you haven't seen anything on the ultrasound. Then you want to see those tiny little dots of enhancement, intraductal lesions. They're never seen on contrast enhanced mammo. And because of the compression, again, what happens is when we give the contrast, the first 2 minutes we don't scan the patient, and we start positioning after 2 minutes. So it's the third minute that we get the first image. By that time, a lot of benign things have enhanced. But if you see the MRI, the ultra fast images, we are scanning the patient as we are injecting the contrast. So it's the in the first 60 to 90 seconds that we are doing ultra fast, if you're seeing something enhancing at that time, you're really confident this is sort of malignant. Here, in contrast, we start scanning only after at the third minute. So a lot of we might pick something enhancing, yes, but to characterize it, like we don't have a diffusion there, so we cannot characterize. We cannot tell whether there is fat or no fat. We cannot tell about the kinetics. So all these things which help us characterize on the MR, we can't do on contrast enhanced mammo. So everything that we see on contrast enhanced mammo has to go for biopsy then. So we cannot then, really bring down. Otherwise, biopsying every tiny little dots that you may see on contrast enhanced mammo becomes difficult then. So characterizing and putting a lot of things into Barrett's 2 or 3 categories is easier on MR. And then again, inframammary folds, all those problems that you have with mammo, the inframammary folds a lot of times are not included in the mammo, or the posterior breast doesn't get included on the mammo. They will not get included even on the contrast enhanced mammo. So practically, I still find challenges with contrast enhanced mammo, and it's only when the patient doesn't want to go in the MR because she's claustrophobic or she has these pacemakers, etc. That's the time when I
think that Smriti, hi, you're there now. So basically, fat, Jyoti, would you not pick up on a mammo in any case on the initial low dose thing? So and plus specificity is
Madhvi,
yeah, sorry.
fat, if it is a small lesion, you may not pick it up all the time. Unless if it is a dense breast, you may, if it is an area of fat necrosis and you see a tiny little nodule there, that you would not, you see that fat. So practically, I still feel it needs to catch up. It's not
Well,
yet there.
I'm remembering fat necrosis cases that have enhanced nicely on MR, and we have biopsied, so I guess it works always.
Now,
I think
you see fat at least.
I think
Enhance, but you see the fat also. So even if you biopsy, you have that, you would like to get a fat necrosis diagnosis there. It is much more acceptable then.
Uh,
Can I interfere? I think MRI today, the best radiologist has enough experience.
Yeah.
Contrast enhanced mammography still is in a developing phase, and most of the centers don't have the experience of the contrast enhanced mammography. Maybe 2 years, 3 years down the line, we may be more confident on contrast enhanced mammography than the MRI today.
I agree. I agree. But contrast enhanced mammography is definitely a player to consider because of
Yes, yes,
its
absolutely,
ease. Yeah,
absolutely.
because of its ease and the short time. So you see, there will always be some cases which need MRI,
Yeah,
but there will also be many cases which can be, covered with just
manage on
contrast
contrast
enhanced
enhancement.
mammo.
Yeah,
So
yeah,
we need to be cognizant of that. That in this era of very personalized medicine, even radiology is personalized. To
yeah.
each case, the radiologist can decide which is the best
Yes,
modality.
absolutely, absolutely. Yeah.
Can I make a comment here? Although we look at MRI as a problem-solving tool for us clinicians, but sadly, within our country, there is so much of heterogeneity in the quality of the reporting that many a times, despite getting a contrast-enhanced mammogram, MRI, we still are groping for answers. It happened today with me that there was a post lumpectomy MRI which was carried out, and there was a lesion elsewhere, very far from the lumpectomy cavity, which was not palpable. And despite getting mammogram, ultrasound, and MRI, I was not able to decide whether I should be offering a conservation to her safely or I should go for mastectomy. So, my question here is there any quality control the Association of Radiologists of India, or for that matter, BC, is something doing to, improve
Where
the
is the quality
quality of
control in medical
reporting?
healthcare in India?
So there
And
has to be something.
until BC can have some teeth as to a regulatory body comes into being,
There's no
and
regulatory body.
yeah, so there is no regulatory. So we can only have more and more hands-on workshops to
Yes,
increase the expertise,
Yeah,
and that's what
right.
BC is always trying very hard. And I think we have, slowly made inroads in that direction
absolutely,
with the
Absolutely.
mammo as well as with MRI.
absolutely.
Yeah.
So
Absolutely.
I think that is a very good point because a negative approach in terms of maybe regulation or barring or banning may not work. It is only how to enhance the skills. And as far as BIRADS is considered, like we see so many reports of breast imaging coming without a proper BIRAD category being reported. So these are some things where dissemination, education is really the need of the hour, and probably some more frequent activities within the radiology community so that we get actually a standardized report from wherever we get it.
Yeah.
True.
So moving to the next question, a small DCIS planned for BCS. So should MRI be done always, or
The only thing that I can say is if it is a very high grade DCIS, and also like the case that I had shown, that lady had a nipple discharge, and the calcifications were very, very posteriorly. So basically, if you're getting discharge from calcifications posteriorly, there are chances that, and it's a high grade DCI. So there is a high chance, like you have to also think, she was a young patient, very dense breast. Generally at times you might see some changes, otherwise the non-calcified, you can see some tubular densities. In fact, a little bit of tubular density was seen in addition to the main calc. So high grade DCIs, yes, it is needed if it is not a fatty breast, if the patient is getting nipple discharge, where is the position of the calcification. So these all things that you have to keep in mind.
Right.
Low grade DCIs, it's not needed.
I think, Dr. Prekshi, we can take one more question because it is already
we are already
8:07.
Yes, ma'am. So here in BRCA carriers, whether there is a role of contrast enhanced mammography.
So CM as a screening tool for high risk screening.
Yeah.
Dr. Smriti ma'am or Madhvi ma'am.
Smriti, please.
Yes. Actually, for high risk screening, I think we should still rely on MRI because of its very high sensitivity. We don't want to miss even the tiniest lesion. And because we have now abbreviated MRI, so that takes care of the long time in the magnet. So I would say high risk screening, we are a little way off for contrast enhanced mammo to make any progress.
Yes.
Now I would like to invite Rajiv sir to give his expert comments and on this whole topic.
Good evening to all of you. I think the experts have already spoken for the last 2 hours, and I have the privilege of working with two of them, Madhvi and Jyoti, for a decade with each, and I have learned a lot. The message that I want to convey today is that the surgeons cannot work without radiologists. And that because today 75% patients are going for neoadjuvant chemotherapy. So the surgeon and radiologist have to coordinate from day one. If they miss it, they will be landing in either unnecessary mastectomies or underdoing a breast conservation surgery, leading to either over surgery or a high rate of local recurrence. Another very important thing is that, as Madhvi mentioned, that radiology and pathology discordance. If there is a high risk of suspicion on radiology, your biopsy report comes at either a fibrocystic disease or ADH, I think you have to take that into consideration and do a lumpectomy or something or a rebiopsy to confirm that, because we have burnt our fingers on this issue also. So that is what I want to convey, that today radiologist and surgeon cannot work in isolation. They have to work as a team along with the medical oncologist. I think this has to work together. Radiologist works with me during the surgery also, because when I do a excision of a non-palpable lumps, my radiologist has to stand by, do a wider wire-guided excision or a clip-based excision, and they have to do a radiology and X-ray of the specimen and tell me whether I have gone wider enough or not. So my only message today is that breast cancer management cannot be done in isolation. It's a teamwork, which is a pathologist, radiologist, many times a medical oncologist and surgeon. They have to work in close association. In fact, probably Jyoti may remember, we used to talk 4 or 5 times every day on telephone for a lot of cases. Thank you very much. And now hand over to Prekshi for vote of thanks.
So before we wrap up, I would like to extend my heartfelt thanks to all the faculty members, Dr. Palak, Dr. Smriti ma'am, Dr. Jyoti, Dr. Madhvi ma'am, for sparing their valuable time and joining us here today, giving excellent insights on this very important topic. And also thanks to them for staying till the last session. Then thanks to all the delegates for your active participation. And without your presence, actually, your presence is elementary to the success of our webinar series. Then thanks to all the organizing team, FSIBC as well as APSI, my seniors and my colleagues for all your guidance and support. Then last but not the least, thanks to the mighty duo team. Without your hard work has actually ensured the smooth running of this webinar. And Sunidhi needs a special mention. You have always been very cooperative and helpful. So with this, I would also like to say that around 4th of September, we will come again with the third webinar of this series, which will focus on the image-guided interventions in breast cancer. So we'll share the details soon. Till then, thank you and have a wonderful evening. Good night, everyone.